So morning, my name's Beth, I'll be leading the huddle. Did you all receive a test, please?
Yes.
Yeah. So first we introduce ourselves by name and job title. So I'm Beth and I'm for outreach today.
I'm one of the PSC trainees.
I'm Justin from Site Team.
I'm John, I'm on the General Resuscitation.
The Bristol Royal Hospital for Children's Medical Emergency Team operates a huddle proforma where they meet first thing in the morning and allocate staff roles for any arrests or medical emergencies that might occur during the day.
This does not include emergencies and ED, and please make sure you're happy to carry out your roles. So we're basically treating all med calls around the hospital as COVID.
The proforma has been adapted for the current COVID-19 epidemic by describing inside team members and outside or support team members.
Okay. So inside team, so only team leader who is the PICU trainee.
Yep.
Very much happy with that. Airway and ventilation team, so experienced anaesthetist, so Lisa Sarah, I think. Airway and ventilation assistant. Yeah. Cardiovascular team lead, which is CPR and drugs, so there'll already be a ward nurse with them, so we'll support them. And then the Ped HGU reg. So Pippa, are you okay to bring the defib in? Yeah. So these people are only sent to the room if a resuscitation or CPR is needed. So the general peds, is it Joe, you happy with that?
Yeah.
Yeah. And you'll be for communication and scribe, and the paediatric HGU reg and team 1 reg as well, CPR and access. Yeah. So the support team outside will be the clinical site team, who are gatekeeping and the Don and Doffin body police.
Yep.
So outreach and a ward nurse will do the intubation, trolley and drugs. The porter, do you know where the CMAC lives?
I do.
And they'll have a paediatric show as well for communication. Okay. So now we should identify any high-risk patients around the hospital. I don't think there's any around.
The roles of the inside and of the support team have been revised, and the team members now know what would be expected of them in a medical emergency.
As we finish, can we please check our agreed roles and our let's switch report now please received. So I'm Beth, I'm on for outreach today. I'm on the outside team doing intubation, trolley and drugs.
I'm a PSC trainee and I'll be team lead.
Justin, Site Team, I'm the gatekeeper on the outside.
John, Jen, Peds, SHO, I'm outside doing communication.
Mike Porter, outside team, vetting care.
Sarah, I'm doing airway and ventilation inside. Rebecca, I'm doing red, and I am doing scribing communication inside.
Yeah.
Pippa, I'm the HDU reg and I'm cardiovascular lead.
Karen, I'm going to be ventilation assist on the inside.
So hello, welcome to your simulation. Thank you for taking part. So I'm just going to introduce the scenario for you, and I just want you to treat it as if it was a normal patient for me.
Okay.
So this is Dylan Jones, who's a 5-year-old boy. He weighs 20 kilograms. He was admitted to the ward this morning with exacerbation of asthma. He's known to have asthma and has regular twice daily Clonal inhaler and salbutamol inhalers, PRN. He's presented to Children's ED this morning with shortness of breath and increased work of breathing and increased use of the salbutamol inhaler at home.
Okay.
He had a burst of salbutamol inhalers on arrival to PDD this morning and an oral dose of prednisolone.
Okay.
This had a good effect, but only 30 minutes after his burst therapy, he had an oxygen requirement with oxygen saturations of 90% in air.
Okay.
His work of breathing had improved initially with inhalers, but remained moderately increased. So he was accepted by the general paediatric team and commenced on Optiflow after arriving on the ward. He had COVID-19 swabs taken and they've been sent, but we're still waiting on the results. When he got to the ward, he was commenced on 20 litres per minute of Optiflow and 20% of oxygen, but his work of breathing has remained moderate since then and is needed salbutamol nebulizers hourly since arrival to the ward. He was reviewed and his Optiflow rate was increased to 30 litres per minute and his oxygen was increased to 50.
Okay.
And he has been seen and accepted by the HDU team. The plan was to continue on these settings and continue on hourly salbutamol nebs, and they would re-review in 1 hour.
Okay.
The HDU also inserted a cannula and prescribed IV fluid maintenance, and he now has plasma light running through that cannula. So you're the nurse looking after Dylan, and you've just come in to review him. So what you've done is you've come to the, because of the Optiflow and needing the PP requirement, you've reviewed him from the window and you've noticed that his work of breathing looks harder than what you had seen earlier. So you have donned your PPE appropriately outside and have now come into the room to review him further. Okay. When you're outside, you also notice, as well as worker breathing being worse, you've actually started to see a dip in his oxygen saturations as well. Okay. Mum has been resident, but she's gone home to collect some belongings and will be returning later to see Dylan. Okay. Okay. Yeah. You got any questions?
No, I don't think so.
No, thank you. Yeah. Okay, carry on.
Okay, so I've just been to Google. So. Hello Dylan! Is he responding to me at all?
Not really, no.
Okay, so what we... Okay, so that's a 79. Okay, and his rest rate is really low. Okay, so I'm just going to call the emergency doctor. So I'm just going to do that. Are you okay? Can you put out a 222 medical emergency and state suspected COVID, please?
Yeah, we'll do.
The first supporting nurse now puts out the medical emergency call, specifying this may well be a COVID patient.
Call Caterpillar, B-side, route 28.
Meanwhile, the nurse in the patient's room prepares to support the child's ventilation. She does this using a bag valve mask circuit with an HME filter placed between the mask and the bag. This can be shown in the image displayed.
Hello there.
Oh, hi
what's happening?
Justin.
What's
Hi,
happening?
excellent. Are you on for site?
I am site today, yes. What's
Okay,
going on?
great. So we've got a child in there. Emily's asked me to put out a MET call, and
Okay.
because it's an aerosol generation procedure, you're all going to need to put on level 3 PPE. Okay? That's found in the bottom of the research trolley.
As management of this patient will invariably include aerosol generating procedures, full level 3 PPE should be worn. This includes disposable gloves, a disposable gown, an FFP3 respirator which has been fit tested, and disposable eye protection.
Going in. Okay, brilliant. Do my body. Okay. Okay, gloves are on the wall, guys.
Here, Justin, in dark blue, is acting as a gatekeeper, ensuring that the appropriate PPE is worn and that only the inside members of the team enter the patient's room. During this time, the patient has deteriorated still further and is now in cardiac arrest. Whilst the team outside are putting on full PPE, the nurse inside is managing the patients alone.
Anyone else involved? No. Okay, great. Yep. Think for the PICU nurse, I think, just in here. And PICU consultant. Reg.
Team leader really. There, fantastic. Yeah. There, good stuff. Scribe, there's your paperwork.
And if you let us know anything you need, guys.
You're going to take the D7.
Okay, great.
Cardiovascular leave.
Okay.
Sarah, what do you need, love? So it's a 4-5 microcuff tube, a Cadell, a size 2.5 LMA, and a Max 2 laryngoscope, please.
Hi, my name's Omar, I'm team leading.
Here, the team leader introduces himself and takes stock of the situation. The team then go on to manage the patient as per the Resus guidelines for paediatric cardiac arrest, shown below.
15. So he had saturated in the 70s, and his rest rate was about 6. So I've just started with 5 ventilation breaths.
Okay.
And I've just been doing 15 to 2 ever since.
Okay, and what's his background?
15. So he's a 5-year-old called Dylan Jones, who's been in with viral-induced wheeze. He's had an oxygen requirement and has been on Optiflow.
Okay. Can someone take over from chest compressions?
The emergency team has now organised itself into an inside team, where full PPE is worn, and a support or outside team.
He was referred to HU team an hour ago because of his Optiflow requirement.
Okay.
And he was just about to be reviewed. Sure. And I noticed he desaturated.
The inside team has organised itself around the patient as shown, with the airway doctor by the head end and the team leader by the foot end of the bed.
2 minutes.
Yeah.
Would you mind putting on the lead for me? I want to assess the rhythm.
Okay, so I'm just going to try and put these leads on, so I'm going to finish.
Can we draw up some resuscitation adrenaline as well, please?
So at time of CO2 as well as we got
So any kind of CO2 when the surveillance should
Lines of communication between the inside team and the support team remain open and active throughout the arrest.
Can we do a pulse check, please?
Okay. No pulse.
Okay, continue CPR.
I'll be back in a minute.
Are you setting up for intubation?
Yes.
Yeah.
As the cardiac arrest management continues inside the patient's room, the support team, outside, prepare and check the requested kit and medication doses.
Yeah, okay.
Should we drop some adrenaline?
Yeah.
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 So what does he weigh? 20 kilos. Okay, so 400 mils. Okay, so we're going to be a while.
Requested medication can then be handed back through the door into the patient's room.
Adrenaline, it's just on its way.
Adrenaline is coming.
Do we are adrenaline?
That's adrenaline.
1 in 10,000.
Yeah. Do they want any intubation drugs?
Should we get some more adrenaline ready?
Yeah. So this is 2 mils of 1 in 10,000.
Okay.
Yeah.
Yep. Okay, great.
Adrenaline is going in.
Back inside the room, the patient is intubated using a cuffed tube. The cuff is immediately inflated and the ET tube attached to a bagging circuit with an HME filter in place.
And if you just attach the bag and start bagging.
If a Mapleson F or cope set is used to bag the patient, the HME filter can be inserted between the patient and the bagging set as shown.
It's up there on your right. On your right there.
Pippa, if I take over chest compressions, would you be happy listening to the chest? I'll come.
And Pippa, when you're having a listen to the chest, can you just feel for the trachea as well to see if it's central or not?
You stop it?
Come on this side.
Yeah.
I'll listen to the chest.
So we're doing continuous chest compressions now?
Yep.
Okay.
So another 2 minutes from the last check, please.
Continual chest compressions is exhausting in full PPE. The team leader should try to ensure that the clinician giving chest compressions is regularly swapped.
Air entry. Air entry.
Equal air entry and
Brilliant. So I don't think it's tension pneumothorax from the sound of things. One reversible cause. Have we given the plasma light, please?
No, we haven't.
Shall we give 20 mils per kilo of plasma light?
Yeah.
To address any hypovolemia?
Yeah.
Communication within the team is difficult whilst wearing face masks. The correct use of a scribe can help with this and enable the team to perform more efficiently.
And we're still in what looks like PA arrest, continuous chest compressions. And every other one will give adrenaline, so every 4 minutes adrenaline. Is that okay?
Yeah. Have we got any more adrenaline in here?
So let's get at least 2 or 3 lots of adrenaline drawn up, please.
And some flashes, please.
Okay, so in terms of the reversible causes,
the team leader is now discussing the reversible causes from this paediatric arrest and ensuring that each factor has been considered. The reversible causes can be seen below.
Plasma light, electrolyte disturbances. Is there any way we can do a gas, please?
Would you like another access?
Yes, please. We just put in an IO.
Yeah.
Could I please get would you like another dose of adrenaline now?
Yes.
And a gas.
Sorry, scribe.
And the gas.
When was our last adrenaline? What time?
Our last adrenaline was at 15:45.
Is it 4 minutes since then?
No.
Okay. We'll let you know, is that okay?
Okay, yeah.
Gas syringe.
Let's do a gas, see if there's any
Gas syringe.
electrolyte abnormalities that we can correct and get additional access as well.
Do a step for this CPR.
Okay. Other potential reversible causes. Pericardial tamponade, unlikely given the history. Electrolyte disturbances possibility given has been having bronchodilators, so we'll see what it is on the gas.
For the IO,
Thromboembolism unlikely, poisoning unlikely. Bedside nurse. Sorry. What medication were they on? Was he on any infusions or anything?
Just plasma, which has only just started.
Okay.
And hourly salbutamol nebulizers.
Sure. Thank you.
And then he had prednisolone in ED as well. Already.
Brilliant. Thank you.
Okay,
and how does he feeling like when you're bagging him?
2, 1.
A little bit tight, but good air entry well actually.
Good.
IO in and gas then.
Okay, so let's do another pulse check.
Okay. And there's no pulse.
No pulse, and it's still PA arrest.
Is it
so
time?
Continue chest compressions, and let's give another lot of adrenaline, please.
So it's just labelled in that tray there. And there's a flash.
My working diagnosis is this is hypoxia secondary to bronchoconstriction and arrest. Has anyone got any other ideas?
This is now an established arrest scenario. The team leader has verbalised his working diagnosis and invited the rest of the team to input any ideas they may have.
Hold side.
Adrenaline in.
Thank you. Has that gas gone off?
The gas is pending.
Okay.
Okay, should we, once that temperature's done, stop?
We've got end tidal. Yeah.
We have got an
35.9. 3,
Okay.
2, 1. And we've got another dose of adrenaline, yes.
Okay. So let me know when it's 2 minutes again.
got a blood gas. So a PO2 of 8, a PCO2 of 8.5, a pH of 7.1, a bicarb of 20, a base excess of -12, and potassium is 3.2.
Thank you. Nothing immediately reversible on that from that point of view. Potassium was a bit on the low side, but nothing that I would expect to cause a cardiac arrest from that point. So I think this is primarily a respiratory and a hypoxic driven cardiac arrest, so we need to ensure adequate oxygenation as PO2 is not particularly horrendous, so that's good. So I think we need to continue CPR.
That's 2 minutes from the last rhythm check.
2 minutes. Let's do another pulse check, please.
Okay, so when you feel the pulse, you have a pulse. Just weak,
Okay.
but you do have a pulse.
Okay.
So we will call it there.
Thank you.